Good evening and welcome. I'm Laura Kane. I'm the director of the Stanford Health Library, and it's my pleasure to welcome you here this evening on this Zoom call where we're going to have a wonderful lecture by Dr. Andrea Kossler from Stanford. Tonight's topic is thyroid eye disease, understanding the disease and new treatments. This is a very special topic. It's so specific, and the people who will be watching it are people who are either affected or have family members who are affected by it. It's really so exciting for us to be able to offer this program tonight. Dr. Andrea Kossler is the Assistant Professor of Ophthalmology at Stanford Medical Center, and she's the Director of the Ophthalmic Plastic, Reconstructive Surgery, and Orbital Oncology Service at the Byers Eye Institute at Stanford. She specializes in plastic and reconstructive surgery of the forehead, mid-face, and eyes, and has a special interest in aesthetic medicine and thyroid eye disease. She is the co-director of the Thyroid Eye Disease Center at Stanford Hospital, where she works together with a multidisciplinary team, including an endocrinologist and radiation oncologist, to provide patient-centered care to patients diagnosed with thyroid eye disease. So without any more from me, I'm very happy to turn the mic over to Dr. Kossler. Thank you, Dr. Kossler, for speaking this evening.
Well, wonderful. I just want to start by thanking the people that are on this call and watching this video. And I want to thank Nora and the Stanford Health Library for the opportunity to discuss a disease that is so important to me. Patients with thyroid eye disease are my most appreciative and rewarding patients. So it's a pleasure to be able to bring awareness and understanding about this sight-threatening disease, but also to discuss the hope and the new treatments that we have available now and the treatments that are coming for the future. I will disclose that I am a consultant for Horizon Therapeutics, who distributes the drug TEPROTUMUMAB, and this should not affect my presentation today. So the outline. Tonight we're going to talk and introduce the disease thyroid eye disease. We are going to discuss the pathophysiology of this condition, the importance of early diagnosis. We will discuss treatment options by going through 2 clinical cases, and finally we'll talk about the exciting future of this disease. No discussion on thyroid eye disease would be complete without first backing up and discussing Graves' disease. Graves' disease is an autoimmune systemic condition. Autoimmune means that the body is attacking itself, and this can affect 2 to 3% of the population. Graves' disease really does not get the recognition that it deserves because it does not have high mortality rates on par with conditions like cancer or heart attacks or stroke. But it does have high morbidity rates and high emotional and psychologic rates on par with things like heart attack and stroke. So it's really important for us to recognize this important condition. Most of the patients with Graves' disease, about 90% of them, will have a hyper-functioning thyroid, which means they have a hormone imbalance. And this can result in severe highs and lows to their emotional and functional abilities. Now, the most common manifestation outside of the thyroid and Graves' disease is thyroid eye disease. Thyroid eye disease affects about 50% of patients that have Graves' disease. And thyroid eye disease can be very challenging to properly diagnose because about 20% of the time, the eye findings will present prior to the thyroid history. And then 40% of the time, it will present long after the thyroid disease has been diagnosed. So it's hard to connect the dots and realize why the eyes are developing these changes. Other systemic conditions that occur in Graves' disease include changes to the skin, such as thyroid dermopathy, which can result in painful and unsightly lesions on the front part of the legs, and deposition in the joints of the hands and changes to the fingernails. Thyroid eye disease is an unpredictable autoimmune inflammatory condition. This picture that you see on the right is one of my lovely patients, and she was nice enough to allow me to share her photos and her story. Just like most autoimmune diseases, this disease is a biphasic disease, where it starts with an active inflammatory portion of the disease, where the eyes appear red, swollen, and painful. And the eyes continue to change and worsen. The way they look and the way they function continues to worsen. And that's what my patient here on the right looks like. She has active thyroid eye disease. Then patients will enter into a stable phase, where they don't have the pain, redness, and swelling anymore, but now they have scarring or fibrosis. And the changes that happen to their eyes during the active phase do not typically reverse. Unfortunately, there is not a third phase where things go back to the way they were before. Now, most of the patients with thyroid eye disease will have mild disease, but that does not mean that they don't have symptoms. It can actually be very frustrating to have mild thyroid eye disease because it's very hard to diagnose. These patients are oftentimes told that you're just aging, or you have allergies, or maybe you have a viral infection. It's very frustrating when the patient knows that there is something wrong with their eyes, but they're not being heard and they're not being properly diagnosed. It often takes them progressing into the more moderate or severe form of the disease that occurs in about 30% of patients and shown in this bottom photo here before they can get the right diagnosis. This can result in significant frustration and a significantly negative impact on their quality of life. The thing about aging is aging occurs slowly on a spectrum over time. This is my patient when she was in her youth, in her 20s. She looks young and beautiful. A decade later, she still looks exactly like herself. Yes, some aging has occurred. Now in her 50s, she still looks great. She looks just like herself. She feels just like herself. Maybe she has a few wrinkles. This is what happens with aging. It happens over decades. But this is not aging. Aging does not happen quickly, it does not cause pain, and it does not cause functional sequelae to the eyes. We look at ourselves every single day, and patients understand when there's something wrong with their eyes. So it's really important for us to educate our physicians and our patients that there is a condition out there that results in a little bit of swelling, a little bit of redness, and a little bit of change to the way that the eyes look and feel, and can progress to significant vision-threatening disease if not properly diagnosed early. This is thyroid eye disease. Now, I told you earlier that about 2 to 3% of the population can have Graves' disease, and 50% of Graves' disease patients can develop the eye disease. That's actually not very rare. But other statistics would suggest that 16 out of every 100,000 women or 3 out of every 100,000 men are diagnosed with thyroid eye disease. What that tells me is that we are missing this diagnosis in a significant amount of patients. The other interesting thing about this disease is there is a bimodal distribution of age. This can present in patients in their 40s, and then again, there's another high prevalence in patients when they're in their 60s. But it does not discriminate. It can happen at any age. I actually just got out of clinic and saw a patient who was 87 years old with severe sight-threatening thyroid eye disease. Now, there are many risk factors that can either worsen the disease or increase your risk of developing the disease. Smoking is one of the most easy ones to reverse or to stop to decrease that risk of thyroid eye disease, because when you smoke, you increase your risk of developing thyroid eye disease by 8-fold. Certain types of treatment for thyroid disease can increase your risk of developing the eye findings, such as radioactive iodine. Another important risk factor is simply being a female. Females have about a 10-time higher risk of developing the eye disease than men. But when men do develop the disease, their disease is more severe. And then finally, age. As we get older, our risk of developing the disease increases. Now we're going to talk about the pathophysiology of the disease. And for anyone that has this disease or has a family member or a friend with the disease, it's really important for us to understand the pathophysiology of the disease, because we have to understand the molecules involved in this disease so that we can properly treat these patients. And I love this stuff, so hopefully this isn't too boring for you all. So as I mentioned, thyroid eye disease is an autoimmune disease. That means that the body is recognizing itself as foreign and it's attacking itself. What I have circled here are the B and the T cells. These are our immune cells. They're like our soldiers that are supposed to fight off infections and protect us. They go around and they surveil the body and they make sure that all the cells are in check and that we don't have any bacteria or viruses or anything that's trying to invade our bodies. But in this disease, these immune cells misrecognize receptors on our thyroid gland and around and behind our eyes. And these receptors are called the TSH receptor and the IGF-1 receptor. And these receptors can co-localize together on cells behind the eyes called orbital fibroblasts. These receptors are thought of as the body as being foreign invaders or non-self or antigen. And so then our body will mount an immune response to try to attack this antigen or this foreign invader. And what I have circled in green are the antibodies. Typically, our antibodies are good. They help us to fight infection. But in this condition, the antibody attacks the receptors on these cells. And it's the antibody activation of these cells that results in the symptoms and pathophysiology so typical of the eye findings and of the thyroid changes. I don't expect anyone to understand or even remember this busy slide, but the reason I point it out is I really want to bring home the point that the orbital fibroblast is at the center of thyroid eye disease. It's the key player here, and I have that circled here. The orbital fibroblast is like a stem cell. A stem cell is a cell that can change into different types of cells. Like when babies are in utero, the cells can change into different types of cells. Well, this can do the same. So this cell is located around and behind the eye, and it is able to differentiate into fat, into muscle, and to release inflammatory cells. And this orbital fibroblast has the IGF-1 and the TSH receptors on it. And so when the body recognizes these receptors, these antigens as foreign, and the antibody attacks these receptors on the orbital fibroblast, that causes the orbital fibroblast to differentiate. Basically, the orbital fibroblast gets angry. So when you have antibody activation of the IGF-1 TSH receptor complex on the orbital fibroblasts, this triggers an inflammatory response with tissue expansion and remodeling around the eyes. The fibroblast can differentiate into fat cells, resulting in fat proliferation, can release inflammatory mediators, and hyaluronan, which is almost like cement that gets stuck in the tissues around our eyes and makes our muscles and our orbits less pliable or mobile. It can result in orbital swelling, as well as differentiation into muscle cells, resulting in enlargement of our muscles. This will cause our healthy eye, which you can see a picture of at the bottom center of the screen, which has muscles that are thin and normal fat, and an optic nerve, which is the cable that takes our vision from the eye and takes it all the way to the brain. It takes our healthy eye and it turns it into a thyroid eye disease eye. On this bottom right side, you see these enlarged muscles, this expanded orbital fat, which can compress the optic nerve. And if the nerve is compressed, you're going to lose vision. All of this tissue expansion also pushes the eye forward outside of the socket, which can cause difficulty closing the eyes and can result in breakdown of the cornea or the ocular surface. So we can understand the signs and symptoms that we see in our patients each day by understanding the pathophysiology. I'm just going to go over a few of the common vision-threatening impairments that our patients have to deal with every day. Our patients deal with dry eye disease, double vision, pain to light, decreased vision, a change in the visual field or what they can see within their environment. They can lose their color vision, and in the most severe cases, they can completely lose their vision, which is called sight-threatening or compressive optic neuropathy. The most common manifestation of thyroid eye disease, for anyone that knows someone with thyroid eye disease, you may have heard of the thyroid stare. What this really is eyelid retraction. This occurs because the eyelid muscles develop scarring and fibrosis within them. This results in the eyelids becoming too open. And then these patients can have difficulty closing their eyes. This will give these patients dry eyes and pain, sometimes even vision loss from damage to the cornea. But more importantly, when the patient looks at themselves in the mirror, they start to not recognize who they're seeing. And when their friends and family look at them, sometimes they may think that something looks different. This can result in a social disconnect or a withdrawal from human interaction, from their friends, from their family. And it can result in depression and anxiety. If you were to look in the mirror and not see yourself, the same would happen to you. PROPTOSIS is the second most common manifestation of this disease, and that occurs because of the fat proliferation, muscle proliferation, and all the swelling and inflammation behind the eye. This pushes the eye forward. As the eye is pushed forward, it is no longer protected by the orbit and the eyelids. That makes it really hard for patients to close their eyes. It results in pain and pressure, and the eyes can dry out, their cornea can be damaged, and their optic nerve can be compressed. These patients sometimes have to sleep with their eyes taped closed, and this can result in significant visual consequences. The third most common condition in these patients is double vision or diplopia. It happens in about 50% of our patients. And this is probably the most debilitating symptom that our patients face. This is actually the #1 reason why our patients have to go out on leave from work. These patients develop double vision because of scarring or enlargement or swelling within their muscles. If you take a look at the black and white photo in the top center, this is what the eye muscles should look like. This is, of course, a cadaveric specimen, but you can see the eyeball here, and the muscles are more like these thin rubber bands. There's 4 main ones that help us look up, down, left, and right. But in thyroid eye disease, the muscles get humongous. And you can look here at the bottom left, when the muscles get so large, they push the eye forward, they stop proper movement of the eye, and they can compress the important nerve that controls our vision. If you look at the bottom right picture, this is another one of my patients who was nice enough to share his photos and his story. If you look at his right eye, the right eye is hidden underneath his upper lid, and he cannot move it down. And his left eye is hidden below and behind his lower lid, and he cannot move it up. He is functionally disabled because of the swelling and the enlargement of his muscles. Double vision can be intermittent, which is extremely frustrating because we really can't treat intermittent double vision, or it can be constant. And as I mentioned, it can be very debilitating and limit patients' daily activities. It can affect their depth perception. It can result in nausea, vertigo, headaches, and it can be extremely, extremely difficult to perform their work and their daily activities. So thyroid eye disease has broad implication on patients' lives. The pain and disfigurement that occurs with this disease contributes to diminished mental health, and these patients can have levels of depression and anxiety on par with conditions like AIDS, stroke, and heart attacks. Now, I've shown you a lot of pictures of patients that have moderate to severe thyroid eye disease, and those patients are not as hard to diagnose because the signs and the symptoms are so clear. But it's actually the patients with mild thyroid eye disease that I want us all to learn how to diagnose and recognize and to bring awareness to. Now, because I don't want to show a lot of my patients' photographs unless I've been given permission, I had to take a photo from the internet. This is Wendy Williams, a famous talk show host, and I've learned now that she has been diagnosed with thyroid eye disease. And reading her story on the internet, I learned that she had this disease for years, and she didn't know it. She was misdiagnosed. Because again, the signs and the symptoms of mild disease are mild, but they can still be debilitating. These patients can have pain or pressure around their eyes, a little bit of double vision, maybe transient just in the morning, small changes to the eyelid, so they can be just told that it's aging changes. They can have pain and ocular surface irritation. And having these mild but present symptoms can be extremely frustrating, and it can result in psychosocial distress because these patients are not being heard, they're not being diagnosed, and they're not being treated. It is so important for us to understand and to diagnose this condition early. Not only do we want to stop the progression of the disease, but we want to be able to treat these patients before they develop the moderate to severe disease. Additionally, the way we treat this disease depends on when we diagnose the disease. As I mentioned, this disease is a biphasic disease. So there's the active phase. That's when there's pain, swelling, and worsening of their eyes. And then there's the stable phase. So if you look at this curve on the bottom left, this is called Rundle's curve. On the x-axis is the activity of the disease, either active or stable. And on the y-axis are the ocular manifestations. And what you can see is that during the active phase of the disease, as time progresses, the eye findings worsen. And so we have to intervene early so that we can decrease the severity of the disease. Once they enter into the stable or fibrotic phase, these patients already have permanent disfigurement and can have functional vision loss. As I mentioned before, there is not a third phase where things return back to normal. I think of active disease like a house that's on fire, because that is exactly what's happening to some of our patients. Their eyes feel like they're on fire. We need to diagnose it. We need to hose down the flames. The earlier we do, the earlier we put out the fire, the less ocular sequelae these patients will have. We don't want their house to burn down. So we want to intervene early. And if we can diagnose them early, and if we can treat them early, not only can we decrease the severity of their disease, but now we've learned that we can even reverse some of the signs and symptoms of their disease. But we have a limited window for treatment. We believe that the best time to treat these patients is early in the active phase of the disease, because we can potentially reverse the signs and symptoms that these patients have, and we can stop them from getting worse. At Stanford, we have a multidisciplinary approach to treat this multisystemic condition. As mentioned before, I work in the Thyroid Eye Disease Center with my colleague, Dr. Christy Docio, who's my wonderful partner and endocrinologist. I'm the oculoplastic surgeon, and we oftentimes work together with Kendall Donaldson or Susan Hineker, or members of the radiation oncology team. We work together with the patient at the center of this team so we can provide a customized approach for our patients to not only treat them through the active phase, but to treat them through all parts of this disease and getting them looking and feeling like themselves again. It's a long road, and it takes a lot of doctors because there are a lot of manifestations of this condition. So we are able to work with our subspecialty colleagues to help the many different systemic manifestations that these patients may have. Let's talk about the patient that I presented earlier. When she first presented in 2015, she had pain, redness, and swelling of her eyes for a couple months, and she was told again and again that it was just aging. Then she was told it was allergy. Then she was told it was a bacterial infection. She was seen by multiple doctors and treated with many different treatment options, but none of them worked. It was not until she developed the more moderate or severe form of the disease, with double vision and severe pain and proptosis, before she had the accurate diagnosis of active thyroid eye disease. So what are our treatment options for this condition? Well, back when my patient first presented in 2015, the options were limited. Actually, up until just this year, our options were limited. Our options were limited to steroids and radiation, which were previously the first-line therapies for active thyroid eye disease. Thankfully, we now have a new option. There is an FDA-approved treatment option for thyroid eye disease called TEPROTUMUMAB, which we'll discuss in a moment. And there are many off-label biologic or anti-inflammatory medications that we can try for this condition. We just don't have good clinical evidence that they work. Now, when patients move into a stable or fibrotic phase, don't fear, we can still treat these patients. We have great treatment options for stable disease through surgery. But of course, we all want to avoid surgery for our patients if we can. So our patient was treated with steroids. Steroids at the time was the gold standard for this condition. We know that steroids may work quickly, but the problem with steroids is that it requires a high dose and a long-term treatment for this condition. Steroids have a lot of complications and a lot of side effects, including liver failure and even death. Things like weight gain and diabetes and high blood pressure and changes to their bones and risk of infection. But more importantly, up to 50% of patients can have a relapse of their disease after stopping steroids at a year out or so. And also, steroids is only expected to stop the progression of the disease. But we don't have any evidence or convincing evidence that it will reverse or disease modify the changes that these patients experience. Orbital radiation is another option, and radiation can certainly work in the right patient. It's about 60% effective. But you have to choose the right patients. You have to choose those patients that have early active, moderate to severe disease. Correct patient selection is very important. It hasn't been shown to improve proptosis, but there are some studies that show that it can improve the eye movement. So radiation is another treatment option. But not only does it not work in everyone, not everybody can receive radiation. You can't do radiation in patients that are young, patients with severe blood pressure problems or diabetes, or patients with certain eye conditions. So let's go back to our patient. She was treated with IV steroids. She was given 500 milligrams each week for 6 weeks and then 250 milligrams for another 6 weeks. That is a hefty dose. However, she did not respond. Her vision got worse. She lost her color of vision, and she lost the function of her right pupil, which basically means her optic nerve was being damaged or compressed. You can see that in these visual field photos on the bottom. A visual field should be white. You should be able to see all of your visual field. But in her case, almost 80% of her visual field was black, which means she could not see the majority of her environment when looking through her right eye. So she had vision-threatening thyroid eye disease. This is a more rare subset of thyroid eye disease, which happens in about 5% of patients. And if we look at this picture down here, we can see again, as the muscles enlarge, as the fat expands, it can compress the optic nerve, and that can cause you to lose your vision. Or this soft tissue expansion can push the eye forward out of the socket, resulting in an inability to properly protect or close the eye. And this can result in the cornea or the ocular surface breaking down. Either way, you can lose your vision. Now, vision-threatening disease can be obvious, such as in this patient, who presented with bilateral corneal perforations and vision loss from compression of the optic nerve. But it can also be silent, such as in these patients, who had no idea that they had completely lost the vision in their right and left eye respectively, and completely lost their color vision. That's why diagnosis and referral to an ophthalmologist is so important, because we can properly not only diagnose the disease, but ensure you don't have any vision-threatening complications that must be urgently treated. So our patient had compressive optic neuropathy. The treatment options are high-dose IV steroids, orbital radiation, or surgery. We tried IV steroids in her, but it did not help, and it only helps in about 43% of patients. And so we took her to surgery. What you can see here on this bottom right photo is a CT scan. This is basically a cut of her eyes, and you can see where my pointer is. This is her right eye and her right muscle, her medial rectus muscle. And then right here in the center is the optic nerve. Her muscle is so enlarged that it is compressing the optic nerve as the optic nerve is trying to escape the orbit and travel to the brain to deliver the visual stimuli. And so we had to take her to surgery to remove the bone that separates the orbit from the sinuses. By separating that bone, we were able to make more space in the orbit so that the muscle could move into the sinus and give the optic nerve more room to breathe. This is a picture after the surgery. You can see the muscle has moved into the sinus. The optic nerve now has more space. Her visual field test has now normalized, and her vision is now back to 20/25, where she had previously lost it. Her optic nerve function is now normal. Her color vision is back. But she still has double vision, eyelid retraction. She still has a long way to go. We had to do double vision surgery and eyelid retraction surgery on her. And this is what she looks like after her long, long journey. Let's review her path. In 2015, she presents and was misdiagnosed for months. She was finally treated with high-dose steroids, developed glaucoma, compression of her nerves, and had worsening eye symptoms. She came to Stanford and was treated with surgery and more steroids, and finally needed additional surgery for her double vision and eyelid changes. This is her at the end of her journey, 2 years after she first presented, and she is one of the most thankful and appreciative patients that I have. She actually volunteers at the Eye Institute, so if you come visit me, you may see her there greeting you, because she was so thankful that someone finally was able to diagnose her and treat her and get her vision back. But this was a long road, and the question is, can we do better? And the answer is that we absolutely must do better for our patients. And thankfully, we now can do better. We have more treatment options than just steroids and radiation, and we'll talk about those now. This is another patient of mine. He presented with very obvious thyroid eye disease. He actually had lost vision months and months before he presented to me in his left eye. You can see that his left eye is stuck and hidden behind his left lower lid. He had given up on that eye. He couldn't see from that eye, and it really didn't move at all. But it was when his right eye started to become affected and started to lose the vision that he presented and was very concerned. When he came to us, he had lost vision in both eyes. He could not move his eyes, and you can see from the visual field test on the bottom left, he had lost a significant amount of his visual field on both sides. And you can see from his MRI scan, this is a coronal MRI scan, you can see why his right eye was stuck underneath his upper lid. It's because his superior rectus muscle is humongous. The superior rectus muscle is responsible for causing the eye to move up. So when it's really large and inflamed, it's going to cause your eye to get stuck looking straight up, just like his is. And then his left eye, you can see that medial rectus and inferior rectus muscles are so large that it's pushing the eye down and in. Now, this patient had been treated by an outside doctor with IV steroids, which remember was the gold standard treatment. But this resulted in a heart attack. He had a myocardial infarction. He was no longer a candidate for additional steroids, and he also could not have surgery because now he was on anticoagulants. So we treated him with orbital radiation, but it did not help. So then we were scratching our heads. We were desperate. We needed to do something for this patient, and we were out of treatment options. We considered things like rituximab, which is a treatment option that can sometimes be used for thyroid eye disease because it targets our B cells. But the truth is that studies have shown that this drug does not work well for this condition. Those results are equivocal and sometimes considered a bit controversial. Tocilizumab is another treatment option, and it makes sense that this drug would work, and so we actually tried to get the insurance to approve it, but we do know that there's a high rate of recurrence and a very high side effect profile. But luckily, the drug teprotumumab was approved at the exact same time that we were desperately searching for a new treatment option. Teprotumumab is a monoclonal antibody that targets the IGF-1 receptor. We'll talk about that in just a moment. So we treated this patient with teprotumumab. He was actually the very first patient to get treated with teprotumumab after it was FDA approved in January of this year. He is an engineer, so he was nice enough to share this video that he made of himself, where he took a picture of his eye in the same position and the same lighting every single night before and after his treatment. Now, this is only after 2 treatments with teprotumumab, when the total treatment dose is 8. So this is even before he finished treatment. But what you can see is that the right eye that was previously stuck underneath the upper lid is slowly moving to midline. I'm going to show you that again. The pupil is stuck underneath the upper lid, but every day that goes by, the eye slowly gains the ability to move to midline. And you can see this again here. Before treatment, again, that pupil is stuck underneath the eyelid. It does not move. After just 1 dose, you can now see the pupil right here in the center. And after 2 doses, it moves down to midline. This may not seem like a lot, but to this patient, it was everything. He was able now to function again, to do his daily activities. And actually, one of the most moving things that he told me was that for about 6 months, his iPhone did not recognize him, and he couldn't see well enough to put in the code. Could you imagine if you could not use your iPhone, if you couldn't just call someone or use your email? But after his second treatment with teprotumumab, his facial recognition recognized him again. And it may seem small and it may seem trite, but it was so important to him, and it was actually very impactful for me as well. It really made me a believer. This is the patient's visual field test, just to remind you, on the top left. Again, it's basically all black. And then this is his MRI on the top right with these very enlarged extraocular muscles. And after just 2 treatments with teprotumumab, you can see that his visual field clears up quite a bit. He regains his vision. And that is because these large extraocular muscles, they decrease in size after just 2 treatments with teprotumumab. Now the muscles are smaller and they're no longer compressing the optic nerve. And so he regained his vision. Teprotumumab, which is commercially known as Tepezza, is the first FDA-approved treatment for thyroid eye disease. As I mentioned before, it is a monoclonal antibody against the IGF-1 receptor. And if you'll remember, I told you earlier that the TSH receptor and IGF-1 receptor complex are basically the antigen that stimulates antibody to attack these orbital fibroblasts. If we can turn off the antibody activation of the IGF-1 receptor, TSH receptor complex, we can stop the activation of the orbital fibroblast. We can stop the inflammatory cascade. We can prevent muscle and fat remodeling and stop the hyaluronan buildup in the orbit, which is almost like a cement that stops the orbit from functioning properly. In January of this year, in the New England Journal of Medicine, Dr. Douglas Smith and many others published their phase 3 results of a prospective randomized clinical trial that really showed us that this drug does in fact work. These patients were treated every 3 weeks with an IV infusion of teprotumumab for a total of 8 doses. The study included patients with moderate to severe thyroid eye disease. Only adults were included. There were several other inclusion and exclusion criteria, one of which was patients that had disease of only 9 months of onset. But what the results showed was that 83% of patients had a significant improvement in their proptosis. 68% had a significant improvement in their double vision. And the majority of patients had an improvement in their quality of life and the inflammation around their eyes. The reason why this impresses me is because previous treatments for thyroid eye disease, such as steroids and radiation, were only expected to stop the progression of the disease in a subset of patients. We have never seen a convincing trial that I'm aware of that reversed the sequela of this disease to this degree. We have not seen proptosis improve in 83% of patients or double vision improving in 68% of patients. So not only does this drug stop the progression of the disease, but it can potentially modify the disease or reverse the disease. What you're seeing here in this red box is one of the patients from the study. This is borrowed from their journal article. This is one of the patients before treatment. You can see how angry and red and swollen and proptotic these eyes are. But after 8 treatments of TEPROTUMUMAB, you can see that the eyes look a lot less swollen, a lot less red, a lot less proptotic. Now, this drug is not perfect. No drug is. And I am just cautiously optimistic on the future of this drug, but I'm so far very encouraged by the results that I have seen. Just like any drug, it has side effects and risks, and it is not for everybody. We're still trying to understand this drug and understand who it is best suited for. Risks of this drug include things like developing muscle spasms or hair loss, even hearing impairment, or an increase in blood sugar. However, in the study, these risks or these adverse events were mild or moderate and were typically reversible upon stopping the drug. And no patients in the study stopped the drug because of these side effects. This should not be used in children or in patients that are pregnant, and we should take caution in patients that have inflammatory bowel disease or diabetes or elevated blood sugar. Now, we've talked quite a bit about treatment options for patients that have active thyroid eye disease. Well, don't worry if you have stable thyroid eye disease, because we have treatment options for that as well. I'm a surgeon, I love surgery, and my favorite surgery is thyroid eye disease surgery. But I am willing to give it up if we can find treatment options that can stop the progression of this disease so that surgery is no longer necessary. Surgery is currently the main treatment option for the stable form of the disease. We can perform orbital surgery, where we remove some of that extra fat around and behind the eye that is resulting in some of the cosmetic changes or the prominence of the eye. We can do a more extensive decompression where we take down the bones that surround the eye to make more space so that the eye is no longer prolapsing forward. We can do double vision surgery, and we can do various types of eyelid surgery so that the aesthetic and the functional changes of this condition can be reversed with surgery. This is one of my sweet patients who presented because of significant proptosis, and you can see she's on the surgical table. She should be asleep, but her eyes do not close. She has significant lag ophthalmos and dry eye symptoms. She's about to have a decompression. I just want to show you how this is done. We hide the incision in the eyelid crease or sometimes in the corner of the eyelid. This incision will not be noticeable after her surgery. We then make an incision through the eyelid crease, through the tissues of the eyelid, to reach the orbital bone. For anybody who doesn't want to see the surgical video, you might want to just kind of turn away from the screen for now. And so we make an incision through the skin, through the orbital muscle, or the eyelid muscle, down to the lateral bone of the orbit. This takes us directly behind the eye, where we can remove any excess fat and take down the bone adjacent and behind the eye. So that takes us immediately to the lateral orbit. Now, what we're showing is using an ultrasonic probe. So we take our little probe and we use gentle ultrasound energy to take down some of the very, very thick bone that is adjacent and behind our eye so that we make more space for the eye. And I'll just briefly show you that we just stick our little instrument in this space. We gently shave down some of the bone, and we can make a significant amount of space. I don't know if you can see here, but there's about 6 or 7 millimeters of extra space that can be created by taking down that bone. This is our patient just a few weeks after her surgery. She's now able to properly close her eyes. Her eyes are no longer proptotic, and she's looking and feeling great. I actually just did her upper lid retraction repair last week. I don't have those photos quite yet, but she looks fantastic. This is another patient of mine. He has significant proptosis and eyelid retraction, and he actually had a problem where he had spontaneous globe subluxation. What that means is that the eyes would spontaneously pop out of the socket and get stuck in front of the eyelids. And so we took him to surgery, bilateral decompressions, and eyelid surgery. Now he's looking and feeling great. Here's another patient, classic sequela of eye disease, with pain, double vision, proptosis, retraction, and inability to close the eyes. After treatment and surgery, decompression, strabismus surgery, and eyelid surgery, she's looking and feeling like herself again. So our surgical options do work, but we would prefer not to progress to the moderate to severe sequela of the disease. We would prefer diagnose these patients early on in their disease when they only have extremely mild symptoms so that we could stop the progression of the disease or we can reverse the disease. It would be my hope that one day surgery for thyroid eye disease becomes obsolete. Now, what I want to say is that we do have treatment options for thyroid eye disease currently, treatment options that work great. But what is even more exciting is the future of thyroid eye disease. In the last decade or so, and especially in the last year, there has been so much interest and awareness and education for this disease. It's been really fantastic. And all of this education and all this science has really advanced our understanding of the disease, but has also advanced our ability to treat this disease. So there are many treatments in the pipeline, which is very exciting for me as a physician that treats this disease, and I hope for my patients as well. So in conclusion, thyroid eye disease is an unpredictable autoimmune inflammatory disease. Antibody activation against the IGF-1 receptor, TSH receptor complex is what drives the pathophysiology of this disease. We can understand the signs and symptoms that we see in our patients and our friends and our family each day by understanding the pathophysiology and understanding that fibroblast activation and differentiation can result in some of these signs and symptoms. It is so important to understand and be aware of this disease so we can recognize it and diagnose it early to prevent vision loss and functional sequela. There are new treatment options for thyroid eye disease that can not only stop the progression of the disease, but potentially reverse the sequela of this disease. I want to thank you all for your attention. I want to thank my patient who you're seeing in this photo here, who I love to see every day. I absolutely adore treating patients with this condition because they are always the most happy and rewarding patients at the end of the very, very, very long journey that is thyroid eye disease. If anyone has any questions, please feel free to ask them now. If you have any reason to see me, you can certainly call us at the Stanford Thyroid Eye Disease Center. And here's our information. Dr. Docio and I see patients together in our multidisciplinary clinic, and we would be happy to answer any questions that you have. Thank you so much.
Thank you, Dr. Kossler. This was an amazing presentation and just so much information. To see the progress that's been made in this field is truly exciting, and to have such a great lecture on video for the public to see and learn about it is a really satisfying thing for the health library to be able to participate in. For basic questions about eye disease or other things, you're always welcome to contact the Stanford Health Library. Our medical librarians do research based on completely on scientific information, and they will send that off to you for free. And if you need to get a hold of Dr. Kossler and that slide went by too fast, we can also help you with that. So you can see the one that says, how can we prevent this disease? It's the first question.
You know, the problem with this disease is there's still so much we don't know. Thanks to some of my colleagues, such as Terry Smith or Ray Douglas, we're learning a lot more. But we do not know how to prevent this disease. We do not know why the body recognizes itself as foreign. But now that we understand that that does happen, and now that we think that we understand the antigen responsible for it, while I don't think we can prevent it just yet, we can at least initiate excellent treatment options. The most important thing, because we can't prevent it yet, is diagnosing it early.
Okay, great. There's another one here that is thyroid eye disease related to or in Hashimoto's?
Great question. So I mentioned that 90% of patients that have Graves' disease have a hyperfunctioning thyroid. At the time when you see thyroid eye disease, these patients are going to have a hyperfunctioning thyroid, but they can also have Hashimoto's disease. In about 3% of patients with Hashimoto's disease can develop thyroid eye disease. It is certainly much less common, but it does occur. Patients can actually develop thyroid eye disease who have hypothyroidism, and hypothyroidism is extremely common. About 1% of patients with hypothyroidism will develop the eye findings as well.
Great. How long is the new FDA treatment needed for? Is this an ongoing treatment, or do you reach a point at which you are satisfied with the outcome and it becomes stable?
That's a great question. This drug is brand new. It was just released in January of this year. And so the current treatment plan for this drug, which was basically published in the clinical trials that are available in the New England Journal of Medicine, is that these patients will receive 8 infusions, and the infusions will occur once every 3 weeks. So that's about a 24-week treatment course. Currently, it is thought that only those 8 infusions are necessary. Now, what we need are long-term results. And actually, the company Horizon that sells this drug is working on that right now. They have shown 72-week follow-up data, which is a long-term result, showing that the effect does last in the majority of patients. But we still need to understand more. Now, for some patients in the clinical trials that did have a recurrence of the inflammatory disease, some of those patients were treated again with the drug. So while we do treat patients for 24 weeks, once every 3 weeks for 8 treatments, that doesn't mean that they can't have it again. They certainly can. We're just trying to understand which are the best patients to treat and what treatment protocol is the best one for these patients.
Okay. Here's a question. In the stable phase, is the immune system no longer attacking the eye?
That is a wonderful question. Whoever you are, you have wonderful questions. We don't know the answer to that, but I think so. I think yes, and I think a lot of people are starting to think yes. So it used to be that we would teach our patients and we would teach our residents and our colleagues that thyroid eye disease is this black and white disease. You have stable disease and you have active disease. But what I think that we're learning is that it's not black and white. There is a lot of overlap. And so active disease, of course, is very obvious because of the pain, swelling, and redness. But we do think that the immune system is constantly acting on our orbital fibroblast throughout the stable phase. Actually, a lot of the studies that showed that this IGF receptor, IGF-1 receptor, was present on orbital fibroblasts were done by taking the fat of patients that were in the stable phase. So we do think that there is this constant metabolism and immune turnover in the orbit. And so we are starting to think that patients in the stable phase may respond to this drug. There's just not enough data for me to say that. There's certainly no clinical studies that support that just yet. But those are the types of things that we're researching. At Stanford, we're doing several studies on this drug and on this disease, trying to better understand how TEPROTUMUMAB, but also how a lot of the new drugs can help our patients.
Thank you. Another question, again, about the permanence of treatment. Is surgery a permanent treatment, or is that the same answer for that?
Yeah, I have to admit, I'm a surgeon and I love to do surgery. And when this drug first came out, I remember thinking to myself, oh my gosh, my favorite surgeries I'm not going to be doing anymore because this drug, TEPROTUMUMAB, was working so well. But that would be a good problem to have. In my opinion, surgery does work great. Orbital decompressions, eyelid surgery works really well for our patients. I can't tell you that it's permanent because just like any autoimmune disease, there is always a chance that you can have a relapse, even though it's extremely rare. Physicians who treat this condition have all seen patients that 5, 10, 20 years down the road have another flare. And so it is possible to have surgery, and then 10 years later, the disease acts up again. But it is extremely rare. So other than that rare scenario, surgery does work, and it works long-term.
In that rare scenario, would you then use the drugs that you've described this evening?
Certainly.
Okay.
Any patient that has inflammatory signs and has changes to their eyes that are progressing and changing would be a good candidate for the drugs that we discussed.
Now, here's a question. Can patients have their Graves' disease under control but continue to struggle with TED?
That's a really great question. Thank you for asking that. Yes. The difficult thing about thyroid eye disease, as I mentioned, is it's an unpredictable disease and we don't fully understand it. So it is so common that an endocrinologist will tell me, and this doesn't happen as much anymore, but where an endocrinologist will tell me that their thyroid disease is under great control. And so it's not likely that some of the findings that they're complaining about it with the eye are from Graves' disease. But the problem is that the two diseases can function independently. Even though they're related, a patient can have very active inflammatory thyroid eye disease, but have a completely normal and stable thyroid. And also, the disease, the eye disease, can present before the thyroid findings in 20% of patients. So sometimes the eye findings can be so obvious, but they don't have any signs of thyroid disease, and so it sometimes makes us question our diagnosis. So yes, the two can work separately, they can work together, it's unpredictable.
Are there any lifestyle modifications recommended or suggested to help with thyroid eye disease?
That's a great question. Certainly avoiding cigarette smoke or any type of smoke, either primary in yourself or even secondhand smoke from family members. I even tell my patients to avoid it at restaurants or even on the sidewalk. Just walk on to the other side of the road if someone's smoking cigarettes. So stay away from cigarette smoke. We know that that is a big risk factor. But also I believe that living a healthy lifestyle and eating a healthy diet is extremely important. We don't want to put junk into our body. The more junk we put into our body, the more our body will respond to it. So eating a healthy, green, leafy diet, exercise, sleeping right, trying to control our stress, all of these things are good for our body. And having a strong immune system is, I think, also important for this disease.
And in a related question, is there any research into the relationship of the microbiome of the gut and viral responses of the immune system that promote this kind of autoimmune response?
There actually is. There is a lot of research that has to do with the microbiome and has to do with that subject. I don't know of any convincing studies that have really convinced me too much about that relationship. But I also don't know that much about that subject. I haven't looked into it as much as maybe I should. But I do know that a lot of patients come in and, we just want to make sure, again, that they're eating a healthy diet and having a healthy lifestyle. And there isn't any studies that I could tell you about that has any convincing data to this point.
And is there any research into what it is that triggers the immune system to mount the attack on the fibroblasts?
There is a little bit of research. I don't think we know why the immune system does this, but we do know that when the T cells surveil the body and when they find these particular receptors, they lose tolerance to these receptors and they then recognize them as non-self. So we don't know why that happens exactly. We do understand that it's the T cell that recognizes it, and we do understand on a molecular level what happens after that. We also think that we understand a little bit about fibrocytes and how they play a role in this disease, but we do not know why the immune system does that, or at least I don't know why the immune system does that.
I have a family member using Restasis for thyroid eye disease. Is this an old treatment? His thyroid eye disease seems under good control.
Restasis is an excellent anti-inflammatory drop for the ocular surface. It's indicated to treat dry eye disease. It is not indicated to treat thyroid eye disease. Restasis is basically cyclosporin. It's a drop that stops inflammation, and it is great for dry eye disease. Dry eye disease is also an inflammatory disease. And dry eye disease can be associated with thyroid eye disease in about 65% of patients. But using Restasis to treat the ocular surface will not treat the systemic condition of thyroid eye disease. It may help their ocular surface symptoms, but it won't change what's going on behind the eye, in the orbital fibroblasts, or even in the rest of the body. So your family member may be having their dry eye disease treated with Restasis, and I'm glad that they're responding to that drop because it can work great in many patients. But it probably is not treating the entire condition of thyroid eye disease.
And here we have our last question of the evening because we're just about out of time. Is there a connection between thyroid eye disease and parotid gland calcifications?
Interesting. I have never been asked that question, and to be honest with you, I do not know the answer to that. But I can certainly look into that if you want to send me a message, because I have not heard that question before. So not to my knowledge, is there a connection?
All right, well then we'll ask that person who's asked it to reach out to you. Again, thank you so much for this really engaging and interesting talk this evening. Just so much information. I think everybody who is watching it will probably want to watch it again and share it with people that they know would appreciate it. So for all of us at the Health Library, I want to say thank you very much. And for all of you who are attending, thank you. This was a terrific talk.
Thank you so much, and thank you for the amazing questions and just the opportunity to talk about this disease. Thank you so much. Have a great night.
Good night.